Okay, good morning. I need to break up a good time, good energy in here. Yes, sir. Good morning, well, and I have the honor of serving as the chair of the Cook County Health Board. Good morning. I'm going to ask that the secretary call the roll of attendance, please.
Director Boss?
Present.
Director Green? Present. Director Harrington?
Present.
Director Kim? Present. Vice Chair Lowry?
Present.
Director Masuda Barnett? Present. Director Ryder? Thank you.
I timed that well, didn't I, Bob?
Director Robinson is absent. Director Sorrell? Present. Director Staines? Here. Director Webster Cross?
Present.
And Chair Garza?
Present. Do we have, thank you, Madam Secretary. Do we have any directors participating remotely?
We do. Director Webster Cross?
And can I have a motion to allow director? Thank you.
Second.
Thank you. The motion has been offered and seconded. Any conversation? All those in favor, aye?
Aye.
The ayes have it. We'll go to often the best part of the agenda, employee recognition. I'll pass it over to Director McItis, or Dr. McItis.
A promotion, okay. Thank you, Chair Garza. Good morning, directors.
Morning.
Right. Getting there. Okay, we'll start as always with our new hires as well as our promotions. So first, our new team members. Frankie Shipman Mulo, Senior Director of Community Health. Annabelle Bedoya, Director of Nursing Operations, Maternal Child Health. Lakita Conti, Nursing Director, Ambulatory Specialty Care Clinical Practice. Colin Ferguson, Assistant General Counsel. Amy Helmer, Manager of Cardiac Catheterization and Electrophysiology Lab. And Tracy Taylor, Clinical Nurse Navigator, Cancer Center. And shifting to promotions, these are team members who've earned promotions over the last month or so. Jafar Hassan, Chief Clinical Integration and Innovation Officer. Letty Close, Chief of Staff and Government Affairs. Vanessa Davis, Director of Pediatrics, Subspecialty Services, Medicine. Francisco Angulo, IT Applications Development Director. Erica Navarro, Clinical Behavioral Health Manager. Latoya McLean, Manager of Complex Care Coordination. Karen Jones, Manager of Complex Care Coordination. And Yolanda Ellis, Manager of Operations, Community Health Center, Cottage Grove Medical Center. Welcome and congratulations to all. We'll shift to recognitions and announcements, and we have a couple of pretty big ones this time, very excited about. The first one is County Care. We mentioned this at QPS last week before, but County Care earned a 4-star quality rating with the NCQA, the National Committee for Quality Assurance. This achievement makes County Care the highest rated plan among all Medicaid plans in Illinois. Every other plan received a 3.5-star rating and puts them in the top quartile in the country. Some highlights from the report card include 5 stars for member rating for overall plan services, 5 stars for providing information on members' race and ethnicity, as well as their language preference, 4 stars for member rating of their overall care, and 4 stars for child and adolescent well care. Congratulations to Aaron and his entire county. Well done.
Good job. Good work.
And I forgot to mention, if you had a hand in any of the wonderful achievements, please stand so that we can recognize you. Next slide, please. Thank you. So ACS trauma certification, this we found out just 2 days ago, I believe. So Stroger's Hospital Trauma and Burn Unit recently earned level 1 trauma verification with the American College of Surgeons, which is a first in the unit's nearly 60-year history. This designation is one of the most rigorous recognitions that a trauma program can achieve and affirms the exceptional quality, timeliness, and impact of our trauma care. This unit now stands as one of only 2 ACS Level 1 verified trauma centers in Illinois and the only one in Chicago. Congratulations, team. Well done. Staying with ACS, Stroger Hospital was now accredited by the American College of Surgeons Metabolic and Bariatric Surgery Quality Improvement Program. This is a comprehensive nationwide surgical quality program that's aimed at ensuring the safe and effective performance of metabolic and bariatric surgery. Congratulations. And Stroger Hospital was also recognized by Health Grades with the Pulmonary Care Excellence Award. The award recognizes hospitals with top-tier clinical outcomes in pulmonary care. Congratulations. On September 3rd, our Department of Public Health team joined Cook County officials at Corazon Community Services in Cicero to announce the launch of its Get Naloxone campaign. The campaign educates suburban Cook County residents about naloxone and includes strategic distribution sites. More than 40 naloxone boxes have been installed in local businesses and community partner sites in visible public locations across suburban Cook County for anyone to access for free. Well done, team. Thank you. On September 15th, Cook County Health was proud to join the CTA and Cook County leadership and community partners to launch a new initiative to combat opioid overdoses. CCH has invested in Narcan vending machines to be installed at 5 CTA rail stations. The goal of the vending machines is to increase access to naloxone and meet people where they are with harm reduction resources. Very exciting program. Thanks to all involved. Congratulations to our Department of Public Health team, our Community Engagement and Health Education team, for being honored at the Sisters Working It Out annual gala with the Strategic Partner Award. CCDPH and CCH partner with Sisters Working It Out to advance health equity and uplift communities across. And a few marketing awards. Our communications and marketing team won 4 Pinnacle Awards from the Illinois Society for Healthcare Marketing and Public Relations. Best in Show for Total Health Talk Podcast, Award of Excellence for Total Health Talk Podcast, Award of Merit for the advertising campaign County Care Rewards You, and honorable mention for Cook County Health Brand Refresh. These awards recognize creativity and excellence in promoting the important work that's happening here at CCH. Congratulations. On August 29th, Cook County Health and County Care participated in the West Side Heroin Opioid Task Force annual International Overdose Awareness Day event. This year's global theme was One Big Family Driven by Hope. The team was also joined by CCH Director Tanya Sorrell. The event served as a powerful reminder of the lives lost, to the urgency of prevention, and the strength of a community driven by hope. Cook County Health's Englewood team hosted our first Walk with the Doc of the year at the Red Shield Salvation Army. It was a great opportunity to bring community members and staff together and inspire them through movement and conversation. Thanks to the Community Relations and Health Center teams for their work on the event series. Thank you. And Dr. Courtney Hollowell, chair of our Division of Urology, was selected to help lead a panel of internationally regarded experts to develop the American College of Surgeons Best Practice Guidelines for the management of genitourinary trauma. These guidelines will serve as the internationally accepted gold standard of care for providers managing complex urologic injuries in both a civilian and wartime setting. Congratulations, Dr. Hollowell. And congratulations as well to Dr. Ayokunle Abegunde, Chair for the Division of Gastroenterology and Hepatology, for being one of 15 gastroenterologists nationally selected to participate in the 2025 American Society for Gastrointestinal Endoscopy GI Organization Leadership Development Program. This 12-month integrated leadership program focuses on the business and operational side of medicine. Congratulations. And I think that might be it. Okay.
That's awesome. That's great. That's really great work, and I don't think any of us on the board underestimates what it takes to achieve these types of accomplishments. So one more round of applause. Okay, we'll move to item number 3, public testimony. Madam Secretary, are there any speakers registered to provide virtual or in-person testimony, or sent written testimony be included into the record this morning?
We have 2 registered speakers this morning. The first speaker is Yvonne Love. And as a reminder, you have 3 minutes. I'll let you know when you have 1 minute left, and then when your time has expired.
Good morning to everyone. My name is Yvette Love, and I am the Vice President of ASME 1178. And I have a direct interest in the Salud contract, which is on your agenda for today. As the ASME leader and as a Cook County taxpayer, you're being asked to extend and expand the Salud contract, and we're asking you to vote no. The This contract affects the CCH third-party follow-up department, of which I am the quality manager coordinator for patient financial services under the non-government area. My department works claims that are submitted to our billing department that come back with things that need to be requested from the payers. The payers have 30 to 45 days to respond. However, and they're requesting information like possibly itemized bills, or the account may need a modifier, or medical records, which are actually sent to the various departments so that our members get the opportunity to work the claim. We identify what is needed to make sure that CCH does get the money in the door. Originally, Salute's contract was to work old accounts on that the third-party follow-up was not working. But the contract expanded, and now Salute works system-generated write-offs, not long overdue accounts. And that's where they start to perform the same work as my team. We can see the accounts in the system, which are still in their work list. However, they're zeroed out by the system, which is a notation that the accounts have gone to Salute. Remember, I said the turnaround time for a payer to get the claim to get the claim and respond is typically 30 to 45 days for the money to come into our revenue. Some claims get sent to Salute less than the 30 days after the billing, while we are still actively working the account.
One minute remaining.
I'm sorry. Once Salute receives the accounts, they get paid for our work. And how can our team work effectively when the accounts are going out the door to an outside vendor? Here is an example, just really quick. The claim was billed to the insurance company with a over $200,000 account, which was an ED visit and a hospitalization. The bill was sent out on July 20th. On July 29th, the payer paid the ED bill, but requested an itemized bill for the remaining amount. Our team member worked the account, sent the itemized bill on August 5th. August 8th, less than 30 days later, after the CCH bill was sent out, and then 3 days later, the bill was sent to Salute, which was system generated, the zero, and every Monday, the zero accounts are sent to Salute. This account went to Salute by August 11th. Their contract pays them a percentage of whatever they recover, so they will get paid for our work that has been done. So we will not get the full amount of the money that we were owed by the insurance company. And so we're asking that the union is asking the board to vote no on the extension and expansion of the Salute contract. Thank you.
Thank you.
Thank you.
Next speaker is Domenica Flanagan.
Good morning.
Good morning.
My name is Domenica Flanagan, and I am the board-certified sexual assault nurse examiner for adults, adolescents, and pediatrics who sees every prepubescent child in our system who reports or is suspected of being sexually victimized. Recently, Cook County Health reached a 2-year contract agreement with NNOC. That agreement excluded same compensation, exchanged for a verbal promise that separate negotiations would follow on the issue. Since April 2024, I've heard many reassuring words, but have no proof of progress. So this is my plea. How many more children under 5 must I recommend and coordinate HIV post-exposure prophylaxis for before these negotiations begin? How many more children will ask me, why did he choose me to do what he did, before management actually shows up at the table? Sexual violence against children does not discriminate. It happens every day in every neighborhood, affecting children of all genders and backgrounds. Often the perpetrators are familiar individuals, people who have earned the trust of both the child and their caregivers through effort, relationship, and or position of authority. Conversely, internet victimization is the choice of strangers, as a child's internet access alone makes them vulnerable to predators, some of which actually masquerade as children. Today, generative AI makes it possible to create whole identities as well as nudify images and create videos depicting specific children engaged in sexual acts. This type of child sexual abuse material, CSAM, formerly termed child pornography, is weaponized by pedophiles to coerce children into situations where they can be sexually victimized and to blackmail them into silence. Typically, those who manufacture this content already have access to those photos because they are friends or family members of caregivers. If hearing the realities of sexual violence in our communities is difficult, imagine being the saint who sits with these children and their caregivers, guiding them through medical forensic services, helping them understand what has happened and what is happening, and interpreting exam findings. An attending physician once told me, "Thanks for having the difficult conversations." Those difficult conversations are just one of the many reasons why this work is so deeply excruciating. Leadership has told me that acting as a one-person army on this issue is unsustainable.
1 minute remaining.
To that I say, I know. The psychological effects of this work can never be overstated. But the truth is, I intend to continue this work exactly as I have until it ends me or the system changes. I will keep educating you on the realities of sexual violence at these meetings until the day I can finally say we've entered negotiations, because without an agreement, few will be willing to do this work unsupported. I need your help. Victims of sexual violence need your help. We all have a role to play, and I'm asking you directly to do yours. Thank you.
Thank you.
Thank you, DeMonica, for your advocacy and your commitment. And on behalf of the board, I know we take your concerns seriously. We'll move to item 4, board and committee reports. I'm asking for a motion to approve item 4A, the board meeting minutes of August 22nd, 2025.
So moved.
Second. Thank you. The motion has been made and seconded. Are there any comments or corrections? Okay, all those in favor? Aye.
Aye.
All those opposed? Okay, the ayes have it. The motion carries. I will turn over, item B, minutes of the 9/19/25 Quality and Patient Safety Committee meeting. Director Botts.
Thank you, Mr. Chair. Quality and Patient Safety Committee met on Friday, September 19th at 9 a.m. Committee approved the following action items, which are included in the minutes. Approved 3 Stroger Hospital Division Chair reappointments. Approved Stroger and Providence Hospital medical staff appointments, reappointments, changes. Committee received the following reports, which are included in the minutes. Operations Excellence Dashboard, Goals and Tactics. Next meeting of the committee will be held on Friday, October 24th at 9 a.m. There are no other questions on the minutes. They're being presented to the board's consideration at this time.
Thank you, Director Bott. Can I have a motion to approve item 4B, the minutes of the meeting of the Quality and Safety Patient Safety Committee of September 19, 2025, which includes approval of the following items: 3 proposed Stroger Hospital Division Chair reappointments and Stroger Hospital and Providence Hospital medical staff appointments, reappointments, and changes.
So moved.
Thank you.
Second.
Thank you. The motion has been made and seconded. Is there any discussion or corrections? All those in favor say aye.
Aye.
Thank you. Any nays? Motion carries. Thank you. I'll ask Director Ryder to take us through just a summary of the Finance Committee meeting of 9/11/25.
Thank you, Mr. Chairman. The committee, Finance Committee met on Thursday, September 11th at 10 a.m. The committee considered the following action items, which are included in the minutes. Conditionally approved 24 contracts, procurement items as amended. Requests number 2, 11, and 14 were withdrawn. Request number 13, a request to amend, extend, and increase the contract with Salute Revenue Partners LLC, was deferred to this meeting. It will be presented and considered later in this meeting. Number 12 is pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee meeting whose fiscal impacts are greater than $1 million, which are highlighted for your information. You received and filed grant award related items. We also received and filed transfer of funds. The committee received the following reports, which are also included in the minutes: report of 1 emergency purchase, report of July financials, and report on the the monthly report on agency, reduction plan. The next regular meeting of the Finance Committee is scheduled to be held on Thursday, October 16th at 10 a.m. If there are no other questions, the minutes are being presented for the board's approval at this time.
Thank you, Director Ryder. Can I have a motion to approve item 4C, the September 11, 2025 Finance Committee meeting minutes, which contain the following action items: a conditional approval of the contracts and procurement items as amended, pending review by the contract compliance, and receiving and filing of the grant award related items, receiving and filing of the transfer of funds. I'd like to have a motion, please. So moved.
Second.
Thank you. Motion's been made and seconded. Any discussion or corrections? Hearing none, all those in favor?
Aye.
All those opposed? Okay, motion carries. Item 5, contracts and procurement items shall be presented by Charles Jones, Chief Procurement Officer, and Pamela Casera, Chief Financial Officer, will review the item.
Good morning.
Good morning.
Charles Jones, Chief Procurement Officer for CCH. We have one item before you today, and that item is responsive for contract compliance from the Office of Business Enterprise Development.
All right. Good morning, everybody. Curtis Haley, Chief Revenue Officer. Today, I'm here to request and extend and amend an increase of our Salute contract for 1 year while we go to market, go back out to market. The Salute contract is a zero balance account contract alignment, and what this type of work is there's vendors out there that will come behind and look at all the accounts that we have brought to a zero balance, where our current team has worked them fully, and they see if there's any additional reimbursement out there. They use their proprietary tools to scrub all of these zero balance accounts, insurance accounts, against current payer behavior, typically denial behavior, to see if we've missed any appeal efforts, any billing efforts and such in our current operational environment. Again, they do this after our current team has already worked them all the way down and exhausted all efforts. To date, the Salute performance is roughly about $30 million a year, which represents about 4.5% of our annual cash collections. So again, we're looking to extend this for another year, continue to operate, continue to bring in collections for the health system. As you guys know, with the current cuts in state coverages, we're trying to make sure that we get everything aligned, get all the money we can into the health system as much as we can.
Are there any questions?
Yeah, based upon what you said and what I'm hearing, this is essentially similar to an audit. They review what we submitted and see if there's any money left on the table and go after that money?
100%, correct.
Okay.
Question. So we just heard public testimony relative to this contract. Having heard that, any other information that we should hear from you, which would be in response to what we heard moments ago?
Absolutely. In the comment, they referenced that the Salute work was coinciding with their work, and it is not coinciding with their work. The current team works through their work list, works through their accounts as best as they can to hit a zero balance. They'll accept denials and so forth. Salute is not involved in any of their work while they have the account. They do not touch the account. They do not have the account. They're not even placed with Salute until our current team brings that account to zero. They make the decision to say there's nothing left to do on this account. Once that happens, then our system generates a placement file to Salute to see if we miss anything.
Thank you.
Why is there a disagreement then on what the Salute contract does?
I can't speculate that. I don't know.
Do we sit down and walk through with the representatives of the union who represent the people who do the other collection work? Do they have any transparency into how the contract's used and what the division is between what they do and, what Salute does, because it doesn't sound like it.
Yeah, we have mentioned the operational design within department meetings to our teams and what Salute does versus what other vendors do that assist in PFS operations. May be beneficial to do another one.
Sounds like there's a disconnect.
I agree.
And so is there a specific parameter or algorithm in place? Because apparently the disconnect also appears to be some work that may be done within their auspices is getting financially then credited to Salute. So is there a trigger so that for the length of time or the days past posting that an account isn't brought to zero, then does it trigger for an algorithm to then move to Salute, or what is that actual workup that there appears to be that discrepancy between the point in time when it switches from their purview to Salute's purview, so that there's a clear demarcation of when that may happen?
Yeah, Salute will not receive the accounts unless we deem them or mark them as a zero balance, which means that a denial needs to be transacted, something needs to be transacted on the account to bring it down, which is driven from efforts from our current team.
So, thank you for clarifying, and I want to hear a little background of what Director Sorrell said. Is there a workflow or a written algorithm so everyone understands that, and say an incident that was spoken about in the testimony can be mirrored against that algorithm, so the team can work together to see, what opportunities for greater understanding or a path forward could be?
There is no algorithm that brings the accounts to zero. It's all based on our current team's work and our current team's experience with that account, and whether or not they deem there's no further efforts that they can perform to get paid. And once they bring that account to zero, then we have placement files. We have placement files that bring any insurance accounts that are at zero within a given week, go to Salute for them to upload into their proprietary system to see if there's any collectability that was missed. And then they report back monthly on how we can improve our operations. The goal with a zero balance account vendor is essentially take their recommendations on how they found additional money, train up our team to make them more experienced, more knowledgeable, so that Salute doesn't receive that or finds any additional money.
So is their tool or their platform proprietary?
It is. Yeah.
Okay. So it sounds like we agree that there is a disconnect, and to my colleague, Director Ryder's point, I think there needs to be a conversation. So I'd like that to happen, and then come back and report to us what comes from the conversation.
Certainly.
Thank you. Any other questions or comments?
Yeah,
Yes.
so I just wanna understand better on the revenue piece, or on what they get paid on piece. So it's brought down to zero because it's not collectible, is what someone's assessing. Who makes that assessment? Is it, the people who are doing the collections themselves, manager or supervisor? Where does that change? Where does that decision get made in the chain?
Yeah, so depending on where the accounts are lined up in the work queues, it's the collectors go through and make that recommendation.
Okay.
And then the denial is placed on the account to bring it down to zero.
All right. And once they've been moved to zero, we're not still pursuing those accounts in-house to try to collect?
Correct. As soon as it goes to zero, it does not qualify for any of our work queues.
Okay. Well, my biggest concern is that we have a question in front of us. I appreciate the answer. The only problem that I have is that when I pull on strings, there's always an exception. I'm not saying that there is one here, Curtis, but it's been my experience that when it comes to this stuff, that there's like, oh yeah, there is this one thing, and like I said, I'm not suggesting that's happening here. I want to make sure that there is a conversation that happens where we're reconciling these things before it gets to be a bigger problem that turns into a grievance and another arbitration that then takes a long time to resolve. So I would just ask, Mr. Chairman, that that conversation happens and the CEO can, report back to us on his assessment of whether there's clarity between everybody, between both sides, from his perspective. Obviously, that could be challenged by, the representatives from the union.
And perhaps if there's not some type of demarcation, as, Director Green had mentioned, or some algorithm or process to that, if the process needs to be then put into place. And that may provide the clarity and the demarcation of when it moves from, their workforce to move to Salud.
And I gotta be honest, when you have, I would also ask that these contracts and the subsequent testimonies and, the ping pong ball, I'm the ping pong ball. We can, if I can be present to, hear what's going on, if that's not inappropriate, to help see if we could figure out where we're at, that would be helpful, to me.
Yeah, well, you're the chair of the finance committee, so I think it's.
I mean, this is, yeah.
Yeah.
And as the vice, ping pong ball, I too would like to be a part.
If I understand correctly, this is a 6-month extension. That's what's stated. So 6 months from now, we'll have to revisit it.
It's a 12-month extension.
12 months?
Correct.
It's 1 year.
So we're gonna
A year.
revisit it anyway.
In a year.
But we'll see, and we may have some additional information prior to that.
It's 1 year.
Thank you. Well, I appreciate again the testimonial by Iman in raising this and the engagement and interest by the board. So thank you for that. And so we have a direction for you, Curtis, and we'll hear back from Dr. Merkitis on what comes from those conversations. And I know, because we're all interested, we'll stay on top of this. With that, I'll ask for a motion to approve request number one under item 4A, contracts and procurement items.
So moved.
Is there a second?
Seconded.
Thank you. A first and a second. Any discussion? Any further discussion? Questions? All those in favor, aye?
Aye.
All those opposed?
Opposed?
Opposed.
We have one opposed, two opposed,
Three.
three opposed.
Opposed.
Sorry, Director Green. Three opposed. I believe the motion carried.
So that was Green, Ryder, and.
And, Vice Chair Lowry.
Dr. Bott is trying to oppose.
Dr. Botch opposed as well.
Director, what's the cross vote? I think somebody asked.
I didn't hear.
Would you like me to repeat what I think it was?
There's someone online.
Director Webster Cross, I don't think we heard your, vote. If you're still with us, virtually. Okay, so in the interest of, transparency, a lot of the conversation you saw happening was around whether we can delay this a month. And the concern is that if we do that, then that'll have a negative financial impact on the county's ability to collect that money. $1 million, $1.5 million is substantial, I would say. So I'm gonna ask, with that information being presented to the directors, to take the vote over again and see if that, helps, with your decision. I mean, we were trying to think about another way to, handle it, but I don't know that we would do that at that cost.
Just out of curiosity, what was the vote? What was it?
We're about, I think we're at 6-4.
6-4 for adopting the contract?
Yeah.
Yes.
Okay.
So I'll ask to take the vote again.
So the contract is passing, so I don't know why would you do the vote?
Should I repeat what I believe the vote
Yeah,
was?
go ahead.
Okay, I'm going to repeat what I believe what the vote was. We have, and let me double check, Director Webster Cross, are you connected right now?
I'm connected, yes.
Okay, to clarify, we are voting on item 5A, request number 1, which is a request to amend, extend, and increase a contract with Salud. Your vote on that item is yay, nay, present?
Are we waiting to hear some additional information after they meet, or we want to go ahead and vote now?
We already voted, I think, is the question. I'm just confused because I thought the contract passed despite us voting no, so I don't know why why we're redoing the vote.
Because there was more information to share.
Okay.
Yeah,
Okay,
that's what I did, I shared it.
Okay, all right.
so what I was asked to do was to repeat what I believe the vote was prior to. So we had 10 members voting. I did not have a vote from Director Webster Cross, and Director Robinson is absent. So of the 12-member board, we had 10 members voting. I had Director Ryder, Director Green, Vice Chair Lowry, and Director Bott voting no. So that means 4 nays and 6 in favor.
That's why I'm confused, Ronald. If the contract passed, the additional, if you want the margin to be higher, I mean, if the contract passed, it only takes a simple majority to adopt the contract.
I think it was
Well, it was
5-4,
still
you're
in
trying to get
yeah,
clarity.
that's right.
Position of what
It was in flux before that, though, and I was asked by the vice chair to consider that.
And with the information that I've overheard, my vote will be nay.
6-5.
I thought we had 10.
No, it's 5.
Now it's 11
Yeah.
with her.
Got it.
Yeah. Yeah.
6-5. Okay.
Plus, we didn't have her vote registered, Bob. So we're trying to get it.
Okay.
Okay. Okay, so we have the right number of votes?
So we have, with that vote, we have 6 yays and 5 nays.
Right, okay, so the motion carries.
Just for clarity, I voted against the motion.
Yeah.
I'm just confused because I lost. And I would have thought that it seemed like the intent was trying to figure out a way to pass because of the additional information, but it had already passed. So I'm just confused. I'm not trying to be disruptive or trying to do anything. I was just confused.
We wanted to share the information that was not shared.
I got it.
Yeah. So having said that, although the vote passed, the board is obviously very interested in how this works out. So, Dr. McKay will ask in the next, not even the next month, if there's more information in the next couple of weeks, to make this a priority until that happens. Thank you. Great. I'd like to go back to item 4C, as it relates to conditional approval of contracts and procurement items. And, I will record my vote as president.
You'll need to unlock,
For item 3 on that list. I do not have a, report this morning, so we'll turn it over to Dr. Makaitis to give, the report from the CEO on item number 7.
Okay, good morning again, directors. We have
Morning.
three items for you today. Andrea Gibson is going to share an ARPA update and a strategic plan update. Then we'll have an ACHN deep dive. Again, as a reminder, we are bringing directly to the board updates through our division, so operational updates, quality updates, and so on. So our ambulatory team will be presenting there, and then Dr. Bina Peters will be presenting a nursing operations update. Andrea.
Good morning. Andrea Gibson, Chief Strategy Officer. We can go to the next slide. I think I know what it says. I thought we were doing ARPA first. Do you mind making it slightly larger, Deb? So, as always, we're providing a slide on accomplishments and things that are coming soon that align with our strategic plan. We've mentioned a few of the things already, so I won't read through this. I will say we've launched our safety coach pilot program on the Stroger 8th floor unit. We've achieved a 54% increase in completed mammograms for uninsured patients related to the birthday screening program, and a 17% increase for all populations. CCDPH coordinated a webinar on building a lead-free Cook County, and they had a successful West Nile virus media campaign. The emergency medicine residency program was named among the top 10 emergency medicine ranking by the residents. And thanks.
It gets touchy when I get down to the bottom, I'm sorry.
And we have installed a staff art exhibit on the second floor, and engaged on other employee engagement activities, like painting at the Bronzeville Health Center, doing a paint party for the mural there. Over the past year, we've achieved a 38% reduction in agency spend. We have a new system in place to receive financial credit for unused returned medications. And we've, fixed an issue in our EMR for obtaining revenue for rehab services. Under the next section, the Public Health Department received restored funding from IDPH for their emergency preparedness program. The first linear accelerator installation was completed, and we have a new security platform to improve operations installed. The last section on the completed side is, a retrospective. We looked at our partnership agreements with other hospitals and referral partners, and we have an estimated $5 million in annual revenue to the system from these arrangements. The County Care Choice campaign was launched, and the nursing strategic plan was completed. Deb, do you mind going to the right? So some of the things that are coming soon are a few things in the patient safety arena. We're launching a Speak Up campaign and the annual Culture of Safety survey. We're preparing to open the dental clinics at both Belmont, Cragen, and Blue Island. Food is Medicine is launching a marketing campaign, as well as expanding food programming to Robbins Health Center. We're planning a rollout of the e-sitter at the end of September, so it might have already occurred, but it's happening imminently. We also have made continued progress on the attestation completion so that we can bill for more of our patient visits, and that backlog will be eliminated by the end of this year. We're doing a few things related to the Stroger cafeteria. We're working on a renovation to provide better offerings, better service, but we're also doing a food waste audit with the intention to come up with food waste prevention and diversion strategies as part of a sustainability effort. We also are implementing the Vizient operational database. now that we have provided the data that we have available to Vizient. That'll help us come up with operational recommendations. And finally, we're launching, we're developing a Provident marketing campaign, and County Care is busy working to respond to the state managed care RFP. Director Harrington?
Yeah, do we have, an estimate of what we waste in terms, or is that what the audit's gonna count?
That's what the audit is going to determine, literally looking through the garbage and categorizing things that either could be recycled or even just prevented from using in the first place.
And how long is that gonna take?
You know what, I'm not sure. Okay, we should have results in a couple weeks.
It'd be helpful to have some kind of idea of what we're looking at. Since you've already done your conclusion, it'd be helpful to know what we're wasting in terms of food.
Yeah.
What the definition of food waste is. That's the only way we would clearly understand what you're talking about. I don't know what food waste is. I know I waste food because I don't eat all my food. Some of that throw in the garbage.
Yeah, everything
food
that's in the
waste.
garbage in the cafeteria. I know when I was at Provident a few weeks ago, they were literally shipping the setting aside the garbage for the food waste audit, and I'm sure they're doing the same at Stroger.
Yeah, and another thing that just occurred to me, there's a shelf life for many foods. Would that be considered food waste as
Yeah.
So, yeah, we need to take a deeper dive into so we understand what we're talking about when we actually get the numbers.
Okay.
Because
Well,
we might see the numbers, but we might not know what they mean.
so yeah, our public health team is helping do this. I'm sure you can report back when it's complete.
Thank you.
All right, on the ARPA update, we've hit a milestone here with this report where we've actually spent more than we have yet to spend, which is positive. Since I reported out last month, we have spent $3 million more. The $87 million remaining will need to be spent by the end of 2026. So that's where our focus is, in working to get reimbursements out of the door to our subrecipients and making sure we're continuing to spend that down. And that concludes my report. Is there any questions?
No questions. Thank you, Andrea.
Thank you.
Appreciate it. Let's see, we will now go to the ACHN update reviewed by Craig Williams, Executive Chief Operating Officer, and Claudia Virginal, Executive Director of Primary Care.
Good morning.
Good morning.
Craig Williams, Executive Chief Operating Officer. I am joined here by Claudia Virginal, who's our Executive Director of Ambulatory Primary Care Operations, and also Beth Bakovich, who is our Associate Chief Nurse that works very closely with us in ambulatory. Before I start, I will ask you all to be very nice to Claudia. This is her first time presenting to the board, and she's a little nervous. I also want to recognize. I also want to recognize Claudia. She's new to this role. She was appointed to this executive director role back in July.
Congratulations. Congratulations.
I do want to say we got 120 resumes for this position.
Wow.
I think we brought in 10 people, and Claudia won it out as an internal, and I'm very proud of that and very proud of her. So with that, I will move on. Sorry, I had to just take that opportunity. So I know you've all seen this map, but basically on the left side, you know, that the first really 3 sections really outline what is comprised of ACHN. And you can see we really have a geographic diversity across Chicago and, you know, across 15 sites where we provide our ambulatory care. I always say that ACHN and ambulatory is the most important part of our system, and you can clearly see that with 15 of 22 sites, we dominated 68%. So really proud of the work we do across ambulatory. Next slide, Debbie. So just, we tried to present today really how we're doing against our goals across ambulatory and how that relates overall to performance as a system. Our key financial metric is really patient visits. And I would say in specialty, we're having a great year. We're 9% above budget. I think this detail shows you where we provide our specialty care, but at a high level, you know, about 55% of our specialty care visits are provided here at the central campus between the Stroger specialty clinics, what happens here in the professional building, Harrison Square with our physical therapy visits, and then core. So that's about a little more than half of what we do. We also have a big presence at Blue Island where we do about 8% of our visits in specialty, and St. Stack is about 6%. So specialty has been really strong this year. I think you've all seen at the board and finance committee that primary care has been lagging a little bit behind. It's lagging behind with an asterisk, I would say. So we are 8% behind budget for the year in primary care. It's about 14,000 visits. The driver of that is the 5th line down, which is the Belmont Craig and New Arrival Health Center. As you know, new arrivals to the city of Chicago has sort of started to go down at the beginning of the year and has completely dried up, and we've actually closed that new arrival intake center. And so we did budget for that volume. We budgeted just under 20,000 visits year to date, which is consistent with our prior year, and we only did 1,400 through, I think, mid-January. So that's the primary driver. Without that, we'd actually be a little bit ahead in primary care. To the next page, I want to
I have a question.
Yes.
Is that a non-duplicated account, the 177,000?
Say that again, I'm sorry.
Is it a non-duplicated? I mean, how many individuals? Is it one is that one or is it?
So, if you are an individual and you come, on a day, you count as a visit. If you are an individual and you come and you have 2 visits, so say you go to primary care and you also see your, urology specialist, you'd actually count as 2 visits there. So these are unique individuals, they have visits. So it could be, a individual could have multiple visits during the year and count more than once in the total.
And they would have,
And that's how we generate revenue.
and they would have gone to another center that's specific to that.
That's correct, yes. Yep. So just drilling a little bit more deep on the next slide, Debbie, on new arrivals, I think it's important to note. You know, so the reduction of new arrivals to the city of Chicago and increased immigration enforcement activity has really resulted in a drastic reduction in patient volume from this specific patient population. So I highlighted on the previous slide that new arrival intake. So that previous slide was the budget. This is the prior year. So we're a little over 14,000 less visits, 99% down in our new arrival intake clinic. But I think what's more important is really the impact across the rest of ambulatory. So as we saw new arrival patients, they became part of our medical homes, and they started to use the medical homes, they started to use some of those specialists.
Yeah.
So we've actually seen a 31,000 reduction visits, with 66% specific to this patient population. Certainly across ambulatory, we're concerned about that decline of volume from the population. However, I would point out that because we're exceeding our volume in both primary care and specialty, when you don't count the intake center, we're actually seeing more patients in our core market. So I think that is good news. We've been able to absorb this volume hit while also continuing to care for patients that want to receive care at Cook County Health. I also would note, and I think that this next box really shows the power of primary care, right? So as we see that reduction in new arrivals using our services, we've seen a similar reductions from the patient population across emergency visits. So we've seen 50% less emergency visits from this patient population and almost 400 less hospital admissions and over 1,600 surgery cases. So the great thing about primary care is as you build that primary care and create that glue to your system, that creates volume across the rest of the system in both specialty as well as admissions, emergency room traffic. So primary care is really important.
Craig?
Yes.
In looking at this significant drop then, what are the areas that you've been investigating that might be able to try to make up some of that? I know a month or so ago, we had a very good conversation about the CIRMAC transition and maybe routing folks that have had very good and quality care from CIRMAC into our also very good quality care outpatient, could that be a potential to make up some of that percentage difference, as well as any type of preventive healthcare pushes, a focus on wellness checks, particularly based on the population risks? So for those that, if we look at Black males 40 to 65, we're having a push for, the prostate exams, hypertension, et cetera. For women, the primary care push. Could those types of activities and concerted population-based efforts in that be able to try to make up for some of that difference that we're losing related to the migrant population loss?
Yeah, I think we're doing all those things. I think we'll talk a little bit on the next couple pages about some of our quality initiatives, which is a lot about closing care gaps and value-based care. And I think that's a lot of the reasons why we've been successful as this volume decline, being able to make up for it in other ways, right?
Do we have something to see what has been filled if the migrant populations dropped effective July? Will we have something that's tracking to say what's filling in that gap so that we can see what's being used to look at reasserting those percentages on our bottom line?
I need to think about that a little bit. I think we can certainly show that.
Okay.
And the places where, I think as we continue with these pace of presentations about ambulatory, we continue to add into it. And I think highlighting some of the places where we've been successful and other places where we're challenged, I think would probably start to tease that out.
Okay, thank you.
As enforcement there's been an uptick in enforcement and looking for people that don't have a formal or official status in this country.
Yeah.
More and more people are reluctant to actually go out and seek care because they're afraid that if they go out and they seek care, they might be subject to deportation. So that's affecting a lot of clinics and systems right now. And it's not something that generates income, to be perfectly honest.
Right.
Yeah. But it is something that we would all agree is possibly a human right, and therefore they should have care if the care is available. But if they're afraid to access care, that's a whole different story, and I don't know how we overcome that.
And how we're messaging to them that, hey, you can still access telemedicine care.
Yeah, I think
So,
that,
so one of the things that I can add to that, one of the things that I can add to that is we are increasing the telehealth, utilization of telehealth, because we know the situation, so that's where we're expanding.
Right.
And if I could add, Monday afternoon, like 3 days from now, we're gonna have, 60-plus people coming together from across the healthcare continuum, payers, providers, the departments of public health, state, county, and local, city, philanthropy, advocacy groups, come together to really talk about these types of things, right? How do we, Greater Chicago Food Depository is gonna be there as well, that we've had some preliminary discussions about how do we co-locate in an access point to healthcare where they go pick up their food, right? How can we kind of think a little differently about providing that additional access? So I'm very hopeful that that will kind of spin out additional work groups that will be able to kind of continue thinking about these things, especially as we head into 2027 and start having a lot of, we have the tech sector is coming as well, to really think about, AI and data analytics, what type of tool. The question right now is, what altitude would a tool like that live at, right? Is it going to be the state saying, here's how we prove work requirements, here's how we, kind of streamline the re-enrollment process, right? Versus, is it going to have to be at each health plan for it, right? So I think, and then HFS is coming as well, on Monday. So we're hopeful there'll be a robust conversation and a lot of follow-up coming out of that too.
Beth? Oh, that's on there.
For services, and this is some of our quality metrics that we've been watching through our diet, specifically breast cancer, and we're really pleased to report that our breast cancer screening for women ages 45 to 75 has exceeded our stretch. We had a goal, we met our goal, we exceeded our stretch even. A lot of this was due to adding on slots in our mammography suites across the system, having some Saturday sessions for women who needed to come on Saturdays, and then also by engaging the clinic staff to be able to schedule women into those slots when they're there for their appointment with their provider. So that's been one of our great successes. Our hypertension for blood pressure checks for our patients less than 140/90 continues to trend upward. We have exceeded our goal. We're close to our stretch.
We continue to work on that. A lot of the work that has been done there has been around a hypertension protocol that engages a collaborative effort with nurse visits, the care management and chronic care management visits with the provider, to do some therapeutic dose escalation for those patients who have persistent hypertension, and so that's been great. The other item that's really helped these has been our value-based care, as Craig mentioned. With value-based care, we have our staff looking at the patient panels in advance to identify what those patients' needs will be during the visit, and then helping to meet those needs when they're there for the visit. So that's been very well received and a great asset for us. Our birth to health screenings, we have completed nearly 22,000 mammograms and PSA screenings in 2025. It's a 17% increase in the number of screenings that we completed in 2024. So we're really pleased about that.
And I would just say thanks to Commissioner Lowry's birthday screening initiative, I think that's really created, although we haven't seen as much interest from the outside in terms of wanting to get the screenings, it's really created a lot of fire in our belly to make sure that we're providing that and closing those care gaps. So
I just cannot say thank you enough, you know, and I sit here as a cancer survivor. You're helping us help other people. Still sit here. Thank you.
great. Around transformation and growth, our focus really there has been increasing the number of members that we've paneled across ACHN. That means patients that have our primary care physicians as their PCPs. We've increased that over last year by about 5,000 patients. And that's a pretty steady physician and provider volume. So, you know, I think really great work there. And the focus there really is making sure that we get people in a timely basis when they call. So we've recently expanded the amount of time that we allow patients to book out. We used to only allow patients to book out 14 days. And if we didn't have room in 14 days, we asked them to call back, which didn't make a lot of sense. And so we were actually, I think, doing a better job capturing people up front because we're expanded that a little bit. And we're actually only at about 17-day wait. And then we're also doing a lot to tie people back in on the back end. So if you're not seen within 2 years, you fall off. And so we're doing a lot to make sure that we're engaging people in care. Next slide.
So I'm going to provide an update on the workforce. So ACHN leadership has developed a multidisciplinary team to focus on employee engagement and improving their scores for employee engagement. And we will be holding quarterly listening sessions to obtain staff feedback beginning next month in October. Also, ACHN and the Nursing Professional Development Education are going to be providing ambulatory care nurse certification courses that starts this week, and this is free for all CCH RN. We also have been able to decrease the percentage on agency staff in ACHN from 24% down to 12.25% as of August 31st. And the accelerated hiring impact, in the last 6 weeks, we have been able to onboard a total of 11 team members through this accelerated process, still remaining 79 positions, but pretty much right on track. And for the clerk type role, we were able to revise the job description, and we were able to eliminate the typing test, which was a barrier for us to onboard these teams or these individuals. So this change has enabled us to successfully convert 8 agency clerks into permanent roles. Next slide.
That's the typing test may seem counterintuitive, right? It was a minimum standard that we had for hiring people on. What we're finding is a lot of people that, especially in the agency roles, were coming in and doing really well at the job, but then were failing the typing test when they're trying to come on board. And that role is really much more of a point and click type of role, and so that's why we eliminated that. Just to provide a little bit more color on that.
Thank you. At ACHN, our focus has been on improving overall the staff work together scores, as this measure has an impact on both the patients and the employees. So so in this graph, we're looking at the top box rolling 12-month score, where we have had some, which shown some improvement from last September up to August. We went up from 64% to 66.7%. If we can go to the next slide, please. So some of the initiatives that I'm going to be sharing through this team, we created a team back in April. It's the Press Caney Task Force team, And this team is focusing on working on this specific measure that the staff can work well together. This task force team has representation from different key departments and roles such as provider, nurses, clinic managers, and other staff. The team has focused also on increasing the response rate of patient surveys, which we have identified in decreasing the number of surveys that have not been delivered due to incorrect phone numbers, and email addresses. So far, we have been able to decrease this undelivered patient surveys from 12% down to 6%. Also, in addition to that, all clinic leaders were asked to present, to develop action plans, pretty much tailored to their clinics. And all these action plans were presented during our ambulatory leadership meeting in order to support transparent communication and information knowledge sharing for all of us. Employee results, survey results were recently shared with ambulatory leadership, and we have reviewed key indicators as well as identifying areas of improvement. We also, like I shared before, we put together a multidisciplinary team that is focusing on how to improve the scores of employee engagement through creative strategies. One of those is a Thriving Together discussion or sessions that are going to start in October. And the purpose of these sessions is to bring all our ACHN staff together with structured discussions in order for the individuals or staff to provide feedback, valuable feedback to us in how our teams can really start working well together very tightly. We want to ensure that we are creating the kind of workplace where everyone feels respected, valued, supported, and connected. And these meetings will be held quarterly. What we're going to do is, with the information we're obtaining on this Thriving Together meeting or sessions, this will help us to continue to ensure that our action plans are being productive and we are providing favorable impact to our patients and employees' engagement, as well as enhancing a collaborative culture throughout Cook County Health.
Yeah, looking at the slide, going back to patient volumes, we have a number of ambulatory clinics. So we have data as a whole, but we also have data on individual clinics. It'd be interesting to see how that sort of plays out, where the mean is, people that are below the mean and people that are above the mean. That would be helpful and interesting to see.
Absolutely.
The other question I had was around, again, want to applaud and appreciate all the work around screening and early detection. I was curious about the follow-up and how that's going, because screening may not necessarily lead to follow-up, but if there are things we can do to continue to support that.
Is this in reference to the cancer screening?
Yeah.
So whenever there is a positive result, the attending physician does receive notification. So that provider in the clinic gets that notification and brings the patient back. And depending on what the screening is, we'll identify the next step. So there is screening and follow-up.
We track backlogs and everything on that. So we're in a pretty good place. There's probably only one area that we are a little bit concerned about that we continue to focus on.
And does that screening include genetic predispositions for cancer and other types of activities? Because you might need additional messaging and education to make sure that populations that are vulnerable don't feel at risk related to their genetic material being out there, so to speak?
So I think it depends on what stage you get to with the screening. So take, for example, breast cancer screening. They go in for a screening mammogram. A positive screening mammogram typically means you go back for a diagnostic, and there might be an ultrasound-guided biopsy or an MRI-guided biopsy. That information, once they get to that cellular level of what they're looking at, will then determine if they should be placed into that bucket for some genetic screening, and that we do have as well.
Okay, but for the BRCA gene or potentially the triple X risk, which our populations might be more likely to be affected by that, potentially even than BRCA, Or is there a protocol to be able to isolate what that risk might be to be able to provide additional screening and services?
That's dependent on the positive diagnostic, so beyond the positive screen to the positive diagnostic to the biopsy, and that's done at a cellular level. And yes, so there are those discussions with the provider and then the oncologist when it gets to that point and further workup.
Have you identified any barriers in having those conversations related to genetic testing for clients in the population in general that unfortunately have been vulnerable related to those types of more invasive procedures?
I'm not familiar if there had been any barriers with those discussions. I know that we have that available. I know that that is something that proceeds. I'm not that much into what's happening at that point, if there's any challenges.
Okay, thank you.
But I know it's offered there.
Any other questions? Thank you, Craig. Claudia?
Thank you.
Appreciate it. Okay, we will now move to the nurse operations update presented by Dr. Bina Peters, Chief Nursing Executive.
Good morning, Board of Directors.
Good morning.
Bina Peters, as I said, CNE for the health system. Next slide, please. All of you have seen these slides, for the nursing was driving excellence across the system under the 7 pillars. These pillars are the direct reflection of the Cook County Health System pillars, which is quality, that we are achieving, chasing zero harm initiatives for patients as well as for staff. Also physical efficiency, effectiveness, and create a care delivery model that we can serve all. Also, looking at the workforce planning and workforce development, patient experience, growth, innovation, and transformation, and along with the optimization and systemization. So these are the pillars we were holding to our heart to drive the changes across the system on for nursing. Next slide, please. This is a busy slide, but this is the highlights of all the accomplishment that happened within nursing. And I call it, these are nurse-sensitive quality indicators. These are defined at the national level. So just to highlight, hospital-acquired pressure injury is one of the key metrics for nursing. And as of today, for the last 5 years, we started the journey under the Zero Harm initiatives. We decreased the hospital-acquired pressure injuries by 95%. And what that means by, right? So we avoided more than 1,200 pressure injuries, and all those injuries or incidents can cost the health system. Average cost for a health happy is around $43,000. So if you take all this improvement and quantify it under dollar, it is more than $65 million of cost avoidance across the system through this journey. Next focus item under the quality for the inpatient units. This data include both Providence and Stroger. It falls with injury. As you can see, we are close to a 40% reduction in our falls with injury, and that is an overall more than 400 falls as of today. We are also looking at the CLABSI. That is also a nurse-sensitive quality indicator. CLABSI is the central line associated bloodstream infection. A lot of work is being done in this area where, we also saw a notable decrease in CLABSIs, which is, close to more than 30%. And then the next items we focused on was CAUDI, which is a catheter-associated urinary tract infection, where we have seen close to a 60% reduction. And then we started looking at some other quality indicators on nursing is the restraint utilization. We wanted to make sure that we avoid restraints within the hospital settings as much as possible, because there are a number of studies shows that adverse event related to restraints. So that journey, actually, we are actually one of the best in our national performing indicators, where 6 out of 8 quarters, we actually exceeded, in fact, the top 10 percentile performers for the acute care.
Nurse communication was one of the challenge as well as an opportunity for us. I know this board heard the number of, actions that we put in place to improve the nurse communication, which has a direct correlation to overall hospital experience for the patients. So with that, I'm so proud to report that we have made notable improvement in this area. I know this was one of the lagging indicators, where for the last 6 months, for the last 12 months rolling average, nurse communication score for exposure exceeded our stretch goal, which is the baseline was 6.9, 69% to more than 75%. Same thing at Providence too. We are actually, we got 100% nurse communicator score again. I don't want it to say that is it, but we definitely need to look at the rolling and average. So some of the key factors contributed that improvements are really hardwiring the leadership rounding as well as the hourly rounding. But one of the major factors is that the busiest time in the hospital for a patient throughput is evening shift, where we have least number of clinical supervisors. So we did introduce a clinical supervisor, which is a working title where helps the charge nurses and others to do the rounds and meet with the patient and address the concerns. And we are seeing that as one of the key interventions that improve our tactic and strategy to our patient experience. And medication scanning, it is simple, but that is one of the quality metrics to make sure that the right patient gets the right medication at the right time, and this is being consistently, we exceeded the expectations. So if you take all this, improvement from a quality perspective, that's why, look at the cost avoidance is more than $76 million of avoidance, in improvement in care. Next slide. I also want to highlight some of the ambulatory nursing, which I know the previous.
I have a question.
Yes.
And there's a couple of questions, and if you can go back to the previous slide. I'm trying to understand the data in terms of percentiles, in terms of the number of people that did not have falls. I mean, so I don't know what the number is, so I don't know what 39% is. So I don't know what the magnitude of the difference is. So, and you may not have it now, but it'd be helpful to know what we're talking about in terms of numbers so we could actually see what's happened. And then the other thing is your opening slide talked about priorities 2019 to 2025. So is the time period just 2025 or is it 2019 to 20? That was the first slide.
The 2025 year to date, so
Yeah.
year to date, so yeah, that's a good point. The data is as of
Okay.
August
Okay.
31st.
Yeah, the opening slide just said 2019 to 2025. I
Okay.
just wanted to be clear.
Thank you.
Thank you.
To go back to your address, if you look at the overall incidents, right, that means the total number of incidents we avoided is 2,144 incidents. That is the aggregate of incidents that we avoided through this process improvement. Next slide, please. This is the one I just wanted to highlight some of the work we are doing at the ambulatory care nursing, and it's really focusing on looking at the scope of practice for nurses, right? This is where, they are managing the standard managing the, call process, and really they can address those calls and to address the patient care needs. And also we implemented number of nurse-driven protocols with the chronic care management visit. Registered nurses can do the chronic care management visit, and that is also reimbursed under the CMS standard. So a lot of work is happening at the ambulatory care setting to establish that program. I think ultimately that is going to help to improve the access to the care where the nurses can, address many of the chronic conditions, improve the safety and quality, along with also open the access for provider schedules. So nurse triage program also is part of this initiative where we are really looking at the nursing protocol to manage some of this chronic conditions. At the public health system, there's a lot of work we see happening from a public health nursing perspective. The things I like to highlight are they implemented the nurse video visit, that is a home visit program to augment the existing program to really make sure that people are really addressing and taking the medication, managing the TB program. Also, we restarted the hearing and vision program after 2.5 years, and now we have actually seen more than 4,000, students, Chicago Public Health students within the system. Other big program is that the public health system nursing, along with the entire leadership team, is really bringing the maternal child program, and they actually established the website where we have all the information available to the public, it's like one shop, they can go in and address it, and that is really going to help to improve the overall access to the information that needed to improve the maternal child health program across the county as well as across Illinois. Next slide, please. Also, there's a lot of work is happening at the correctional health nursing where, the goal is to provide safe quality care. And as you can see, one of the key metrics and responsibility for the nursing is to achieve a kind of above 95% compliance on addressing the health request form, which is any detainees, they have the right to request to do a clinical assessment, and that is a nursing responsibility. And we actually exceeded the compliance of meeting that standard within 24 hours of the request, and that is being consistent, and we are continuously performing above 95% for the correctional health system since 2024. Also, the medication compliance and protocol remains to be the standard. We implemented the medication scanning program, and we are actually exceeding the goals, as well as we are also continued to provide the safety, by sustaining a 100% compliance rate in the contraband substance that is not getting into our correctional health system. Next slide, please. I also like to highlight some of the innovation work we are doing within the nursing. We established the Nursing Innovation and Research Center. It's almost 2 years now. We have the structure. Actually, this center or the program will provide support to the frontline nurses to really look at bring the evidence-based practice as well as the research at the bedside to improve the care. They not only, use the evidence-based practice to improve the care, they are also presenting now locally and statewide as well as nationally the work that we are doing to improve the patient care across the system. We also, held our first annual evidence-based conference here in this floor, where we have more than 20 institutions participating and bringing their best practices. Also, we are doing an ongoing collaboration with around journal clubs, as well as we also are doing many things to really bring in nursing, as well as the nursing processes to make sure that we are doing the best practice across the system. We also have training programs in place. Nursing publications are part of this center, as well as a nursing innovation launch where we want to have the frontline staff or the frontline managers to bring some of their frustration as well as their ideas and to see what we can to make that happen, and as well as the execution strategy and also sharing those best practices. So a lot of work in this center. Next slide, please. Just to highlight also that we did the 2 national conferences here. One is the first Midwestern Correctional Conference that was well received, but not only locally but as well as nationally. And also we had our nursing research symposium. Next slide, please. We also were accepted into the National Nurse Innovation Fellowship Program. This is a program actually collaborated by Penn State as well as Johnson & Johnson, the firm, and also the Wharton Business School. So we were actually one of the 15 hospitals across the country accepted to the program. This program brings innovation as well as human-centered design principles to really improve the care at the bedside. Next slide, please. Now, also with all the work we are doing with our nursing shared governance structure, as well as the work we did with the Nursing Innovation Center, the work was recognized at the NAC of the National County Association. So actually the last one this year, County Association 2 recognition award for nursing to really acknowledge the work that we are doing. Next slide, please. Also, this is a huge accomplishment for nursing. Now we have, through the shared governance structure and as well as the group, we actually have a Cook County Health Professional Practice model. And this is the model actually developed by the entire nursing team as well as voted by our frontline nursing staff. And this model will guide us to provide the care with a common purpose and a common vision. Next slide, please. I just also would like to highlight some of the highlights where, nursing Cook County Health Nurses, the nurses were accepted into our nursing research fellowship program. It is through, to New York University, and actually, goal is that they will bring those knowledge to Cook County to really improve, the care across the system. Next slide, please. Also, it's very important that we recognize the work of our nurses as well as our colleagues. So we are actually launching a nursing peer recognition app where people can recognize each other, and this totally, should correlate directly to our employee engagement activities. So this is in a pilot phase. We just launched this last week, and we are hoping to evaluate the effectiveness of this tool in the coming, months. Next slide. Few other activities going on is the Beacon Award. Beacon Award is done through the Critical Care Association, and in order for us to even apply, there's a lot of vigorous work, a baseline assessment to see where we are with it. We did completed the baseline assessment for entire critical care unit. Currently, the burn ICU and the neuro ICU scored the highest engagement score as well as the safety score. So we are ready to, and in fact, we put the application in August. We should hear the results soon, but this recognition is truly demonstrate the excellence that the nursing work is happening to improve the patient safety as well as employee engagement. Next slide. And also, we are applying for OR, our AOR, and Information Organization of Registered Nurses. We do have a Go Clear Award, and this is to make sure that the OR is performing in all the safety standards, again, surrounded by the fire safety. Next slide, please. Also, with that, we have our second annual evidence-based research conference is coming. It's on January 2028. January 28, 2026. So more information will be sent out soon. Next slide, please. Then all of the seen is this work on nursing excellence, this is a busy slide because of but highlights. We are planning to put application for pathway to excellence to recognize the excellence across the Cook County health system. Each entity needs to put the application. So our goal is to have put the application, by 2026, this is the majority of the work, with the goal that at least one entity will achieve the pathways to excellence recognition. Next slide, please. Just want to highlight the workforce. This is something we take pride. Our nursing workforce turnover is actually one of the best in the country. The national average is around 18 to 20%. We are still below 10%. So kudos to the entire team for really bringing this down. Next slide, please. This slide is a busy slide. Let me highlight. Basically, when we did the patient, employee engagement survey, so proud to share that the RN engagement actually exceeded the national benchmark, about 50th percentile, first time in the history of Cook County. And also, this is to really highlight some of the work that we have done with our nursing leadership frontline managers on a training on nursing academy, where we train them on how to work in an environment where engage the staff. Actually, something to highlight is 27% of the nursing units actually rated as the top, performers. And also, when you look at the leader index, 67% of the nurse leaders are at the high index rate. That means, employees feel welcome as well as engaged at the unit level. Next slide, please. There's a lot of work is happening in nursing to really build the pipeline of the future, which many of the things, I shared with this group. Something I like to highlight is our nursing externship program, where we are actually bringing the senior year nursing students, to work with us for the one semester, which is an opportunity for us to really offer them the job to make sure that, they like us, we like them. So currently we have 7 nursing experts doing this summer. Also, I know we are also aggressively working to improve the nursing certification certification because a certified nurse to a specialty really can improve the patient care, patient care outcomes. And we also have a number of recognition programs, including DAISY Awards and others, to really recognize the work of the frontline nurses. Next slide, please. This is something we started the Cook County Health Nursing School Summit, where we bring in more than 20 nursing, educational institutions across the Midwestern to really look at to improve our nursing student placement as a long-term strategy for the workforce, pipeline. Because you look at the data, more than 15 to 20% of the Cook County Health nurses are eligible to retire in the coming 3 to 5 years. So this is a strategy we are building. As you can see, we improved our nursing student placement more than 500% since we started this program. Also, notable that more than 50% of these nursing students would like to consider Cook County Health as an employer of choice. So, hope that with this program we can actually, bridge the gaps in our, vacancies. Next slide, please. This is our nursing vacancy. This is really, we still are at the 37% of the nursing vacancy rate. A lot of work is happening to, to improve or decrease the vacancy, and I'm sure, this HR provided the update. So I'm hoping that in the next 6 to 12 months, we will really address some of the challenges we face by recruitment through the hard work of our HR team. Next slide, please. So with that, there are two documents, to present to all of you. One is our nursing strategic plan, and as well as our 2024 nursing annual report. Some of the highlights are there. So the copies are with you, and I presented the nursing strategic plan draft in May, and that went through the different, committees, including our shared governance through nurses. So this is the final nursing strategic plan that is going to take the health system for the next 3 years to really bring the excellence across the system and also improve our nursing engagement as well as their participation and also their leadership. So with that, just wanted to say thank you, and if you have any questions.
Any questions or comments?
So,
Director Bob.
I'll just start with, saying, it's a tremendous amount of work, and a lot of these efforts, there's a lot that goes behind it. So just want to express gratitude for the progress and the great work around quality and patient safety and supporting nursing, which is an important part of the work along with our clinicians and care teams. The question I have is if there's any particular support you need from the board as we move into this next phase of the strategic plan.
Thank you, Dr. Bhatt. Just want to also acknowledge that, nursing these are nursing quality indicators, right? But nothing can happen nursing without the full, the colleagues and collaboration. True. So right now, I think for me, from a board perspective, thank you for all the support. Now we have structure in place and also the support of really building a strong nursing team. And I think some of them are here because this work is truly, I'm only just the face, but the work is done by the team. So I just wanted to say thank you. We came a long way and your support there, but definitely we will be coming back and presenting. So that, I'll take that offer and come back here, Any other questions or comments?
Just to note how well this looks, how well you've done in being able to harness the strength of nursing in the actual data, the reductions, the improvements overall consistently across the board for everything in these areas, particularly in the areas that we continue to struggle with in terms of workforce development, agency versus ongoing regular staffing. And are there, as I'm looking through the strategic plan, are there any gaps? Are there any things that you say we wish that we could do more? Or as Director Bott said, this is an area that we haven't scoped yet, or how to incorporate either AI or other activities. Is there anything that we can do to help further what you've done so far in such a great fashion and accomplishment in these last several years?
Director Strahl, one area is, if you look at the strategic plan, we all know that we cannot, have the state care delivery model coming for years, right? Lot of technology enhancement is there. Everyone is talking about, integrating technology. So we built in some of the structure about how do we integrate technology into nursing, process. That includes telesitter, virtual care, as well as we are looking at some virtual nursing. So that is part of this work, right? And I want to make sure that as we integrate technology, it's not the work of the nurses, it is the support to a nurses, right? That is coming. And the biggest gap is that we need to address this coming to, this strategy plan is to really address the nursing vacancies, right? Which I think is part of the nursing strategic plan and also part of the sister strategic plan. I don't think a single day, between Dr. Makaitis, Mr. Van Buren, and us talking about what can we to really streamline. And the more and more I learn about our nursing community, people love our mission and the passion. We just need to streamline the hiring process to get the people here so they can stay with us. And also you can see, as I presented, 50% of the nursing students come to our way are really passionate about our mission and they wanted to come. We need to get to a level where we should be able to give them a job. We like them, they like them, decrease the, interval of hiring.
I saw you had the nursing school summit, and I was looking to say, okay, did I miss when the 2025 one is? So we can make sure that we're available there. Do we need to dip more even into high school? Do we need to look at even activities where they're, so folks are even in middle school, high school, are learning about what a healthcare career can accomplish and basically growing our own, so that when someone even, giving them motivation and aspiration to graduate high school, potentially into an entry-level job. Is that an area where we need to look at continuing some efforts at workforce development, even in seed?
I'm so excited. I'm sure Dr. Makaitis is going to jump in. We started a high school engagement program. Also in the strategic plan, we did put our bold vision to bring back the nursing school we had here, right? Remember Providence Nursing School that has a lot of history and value, so it is here. Maybe Dr. Makaitis is actively working with the different programs and the high school to start the healthcare, career as a seed, the high school, and even, we have to start thinking about earlier than that. So you're absolutely right on that.
Yeah, thanks, Bina. So that's part of kind of the broader pathway program idea, right, built around the Providence Scholarship. That was kind of the impetus to think about how we expand and bookend. Those are folks already engaged and enrolled in programs, right? And it's a wonderful program, but how do we get upstream, right? So there's been work with Chicago Public Schools to have students come and shadow. We've started with non-clinical roles, but we did bring some folks in through their internship program at the beginning of the summer. And then we're in active discussions around what's kind of starting the very front end of that pathway kind of funnel into healthcare would look like, so lay people can get into programs like MA training or patient care technician. And then that kind of creates that flow right into, if they're interested in nursing. And then once you're a nurse here, I mean, there's a pathway all the way to your DNP. So, so it's that front piece that we're trying to build to kind of create that path all the way through.
Wanting to hear more. Thank you.
Yeah. That's great.
I know. Commissioner?
I just said that's great.
Oh, okay. I know, with virtual nursing, AI goes into a lot of virtual nursing, and there's a lot of opportunities, across the board, for increasing our deliverables to patients. Question about the virtual nursing. I know there are two predominant models out right now. One model is where you consult with an agency for virtual nursing, and then the other model is that same agency can create a pathway. So the virtual nurses are actually part of CCH. So have you all considered whether or not those virtual nurses are going to agency, or will they be part of kind of the employees here?
Our goal is,
staff here.
Our goal is to build that with it part of the CCH. That's why we started with the virtual sitter, where right now some of the challenges you see is like, multiple patients need one-to-one care and one, PCP to one. Now we are bringing that. Actually, we completed the pilot. That pilot helped us to really understand the workflow, establish policy, the protocol, and all those things. And the next phase, next step is to fully implement through that Cerner, through our own staff and our own people. And that's why I know Andrea mentioned about September, so we definitely like to see that go live, the next couple of months to understand and hardware it. And then we build the infrastructure to build the virtual nursing, right? There are different models out there. We've actually, some of us were in Florida looking at one of the best models to understand what is happening, where the nurse could do admission and the discharge. I can affirm the teaching as a virtual nurse when the other nurse is doing the other thing. So it's going to be a combined model where the care delivery is defined within the scope of virtual care to the primary care, and then, to improve outcomes.
I love that, and even when I don't know if we're talking about the same study, but there's even literature that shows even when you start going into the telemetry floors and the ICUs, those virtual nurses allow for the nurses that are on site to move around, do other things with that wonderful support. That same literature also shows that when the virtual nurse is actually a team member versus an agency member, there's more investment and better outcomes. So thank you for that.
Now, our goal is to, build the team within, because I don't want to be at the bedside maybe, so 5 days, then I get to do one virtual day. So that's how that teamwork is, it's really happening. Also, the other big piece is the clinician burnout is a big discussion nationally, right? Virtual nursing also going to bridge that gap and looking at the burnout, not just talking about nursing, but also other clinicians. There are a couple studies came out that, maybe 30% of the clinician may leave the bedside. That was the latest study came from, recently. I'm like, so we have to bring all these tools and technology to really make the clinicians, the process better. So that's this fully, baked into the strategic plan.
Thank you. Yeah, that's a really good point, because also from what I'm learning, the self-care and the patient is part of patient engagement and not necessarily part of direct nursing care. So it's not necessarily included in this report, but we want to make sure that we're heightening and supporting that area as well too. Otherwise, we're going to have the attrition that will continue to cause difficulties with the vacancy.
Great point.
Go ahead.
Yeah, this is not a question, but an observation. One of the things that distinguishes nursing, at least for me personally, and probably a lot of people, is the amount of time that nurses spend with patients as opposed to other professionals. And there's this tension between being high tech and high touch. So I want to keep in mind that at some point we need to be able to interact with patients in a real way and not just rely on technology to get us to the next point. Because if we don't build those relationships, then we're probably going to somehow impact, what patients do, the decisions they make, their ability to take their medicines on a regular basis. So there is this interesting tension between high tech and high touch, and nurses are particularly high touch. Right. So don't lose that.
Yeah, Director Harrington, it's a great call out and something we need to pay attention to. The intent right now is when we have patient care technicians tied up the entire shift sitting one-to-one, those are folks who aren't helping the nurses out at the bedside, creating those connections. Same thing with nursing. When they're remote, they can do med reconciliations, they can answer call-outs, it lets the nurses who are at the bedside actually focus on patient care a lot more. So that's the line that we're wanting to get up to in terms of how we use technology, not beyond that.
Well, thank you, Bina, for a very comprehensive report that reflects a great deal of comprehensive work that's representative of the investment that I think the county and your leadership and Dr. Makaitis has in the whole nursing workforce function. Appreciate it. Thank you.
Chair Garza, if I could, just a second. I do want to share something rather bittersweet. We're anticipating that this is probably Bina's last board meeting with us. She plans to retire at the end of November. So if I could just talk a little bit about Bina's contribution. She joined CCH in 2018. And in addition to creating our first nursing triennial report and strategic plan, she obviously, having been here, led us through the pandemic and advanced and advocated for the advancing practice of nursing and elevating standards in patient care. Through her leadership, the nursing department's grown stronger. It's become more unified and more rooted in best practice and innovation. And personally, Bina, I know we made a quick connection when I joined in my quality role around how we start advancing, shared governance and nursing peer review and continue to elevate the quality within nursing. So thank you for your partnership and everything you've done for the organization.
Can I say something quickly? Wow.
So Vina, we'll give you the last word.
My last day?
No, your last word.
Oh, my last word, yeah? I'll be.
Can we make a couple comments?
Yeah.
Yeah. Bina, I came on the board shortly before you came over as our chief nursing executive, and there's been a lot of ups and downs across the system. I want to tell you how much I appreciate the relationships you've built with the nursing staff and also with our patients because of that, for the organization. Thank you for all your hard work and hanging in there when things were chaotic, and you've now served under how many CEOs?
Bye.
That's a secret itself.
Yeah, yeah.
5 bosses.
Well done. Well done.
Thank you.
Dr. Bott.
I just say, appreciate your leadership and hard work and collaboration, just the way you go about the work and bring the team along with you in that journey. It's been really great to collaborate with and watch, and just appreciate you also trying to push the envelope in terms of what can we do better, how can we use technology, how can we think about new ways of doing work so that we ultimately impact our patients and community in a very positive way. So just been wonderful to work with you and your team. So thank you. We will miss you.
Thank you, Dr. Bott.
Thank you. Go ahead.
I would say as someone that grew from medical student involved here to resident involved here to fellow involved here and attending involved here, and now being where I am, all stages, I don't even think you remember, but the way you've demonstrated what compassion and care looks like throughout all the, all this, and then to find out that you're a fellow of the American Council of Healthcare Executives too, and not only that, encouraging our team to be there so we understand the nationwide picture, but it also brings more clarity to what we do here. And so not only growing yourself, but the space you've made for our fellow colleagues and team members here to grow themselves too. So thank you.
Thank you, Dr. Gray.
Yeah, I want to commend you for all that you've done. I haven't been in this position that long as my colleague. But I've gotten to know you. I know that you're very compassionate, you're very interested. And not only that, it's the way you build relationships with other people moving forward that has caused you to be successful. But as someone who considers himself fully retired, but people question that, I want you to know that there is an opportunity to serve even when you leave and retire. And we will keep the door open so you come back and if nothing more, smile.
Yeah.
So I'll just say, Director Harrington has failed retirement, and we're kind of hopeful, we're kind of hopeful that you will as well. Stay in the jurisdiction. I'm going to be honored to bring you down to our full county board meeting so we can acknowledge your many contributions. So we'll be in touch, and we'll make sure that it's a time that works for you, okay? Thank you.
So much. Thank you so much.
Yeah, thank you for your outstanding service to the Cook County Health System. You've obviously made a tremendous difference to thousands of people in the county. Thank you.
Thank you so much. I just also want to say, I know we had a new board member, one of our team member presenting. When I started here, people said, one thing I'll tell you, you have to be really prepared for your board update. So I was a bit nervous. I'll tell you my first board update, but I just really want to share with the board that the support as well as the compassion and the whole board, Shay gave it to me is actually behind the secret sauce for my ability to drive the changes to Cook County health system. We came a long way, which I'm proud, but we definitely have a long way to go, to get to be one of the best in the country. At the same time, I want to thank each and every one of you for all, your support. Also, we built a strong team. I'm sure they're not all here. However, it is the work of the team that we built, as well as, the most proud I am today is our frontline nurses. There's a lot of challenges, but they work every day so hard to bring the best out, and all the numbers I can only show because of our nurses. I really wanted to thank them, but probably will be here for next month, and after that, I'll be, maybe I'll join as a retiree, who knows, right? Thank you so much.
I'm going to second that you hopefully will do as well in retirement as Director Harrington is in terms of basically staying in. And now I know why we were texting and trying to connect, apparently, so that I wouldn't fall out of my chair as I'm hearing this today for the first time. But thank you so much as welcoming not only myself, but I'll speak for Director Webster Cross and the first nurses that are on this board, so that we can truly have a voice, because you led the way in making that voice and making that space so that we could come here and also give those significant contributions. And in the ideas that we bring to the table and bring to the entire team, you've been there in support, in answering questions, and being as excited and thrilled to be able to make sure that the nursing care that you give, that was shown in this exemplary report, is also what we can bring to the table in moving forward for Cook County. It was an additional pleasure for us to both be named as fellows for the American Academy of Nursing in the same year, which meant that, yes, we were both very overworking type A nurses. And so I'm a little bit disappointed that you will get the first chance to rest than I will. But I do look forward to your continuing failure to rest, as we're seeing here, and continuing the activities and work that you've done so far. But congratulations so much on the accomplishments that you made, and that we know you'll continue to do going forward.
Thank you, Dr. Stella. Thank you.
Thank you, Rena. Thank you.
Thank you so much. I really appreciate all your support.
Thank you. Okay, we'll move to item 8, which are informational reports. The first one will be semi-annual report from the Employment Plan Officer, presented by Kimberly Kraft.
Hi, good morning and happy Friday, everyone.
Good morning.
Kim Kraft, Employment Plan Officer. So I know all of you are aware of what the employment plan is and what the employment plan office does, but I always like to start off by reviewing for the broader audience those 2 points. So starting with, what is the employment plan? It's the CCH manual that contains structured processes for hiring and other employment actions that are applied system-wide here. What do? They prohibit discrimination. They contain proactive processes and procedures that prevent the opportunity for discrimination. They contain transparent processes, meaning that we're demonstrating through the paperwork generated in our employment actions that we are following all requirements, whether they be the employment plan, law, collective bargaining agreements, and the employment plan also does require that we honor our collective bargaining agreements. Now, what does the employment plan office do? So we are a team of, Cook County Health employees who oversee and support compliance with the employment plan. So the bullets below detail the types of things that we do, and going through those quickly just to provide context for what you will see later in the slides. So we do prepare and present plan-related training and train employees at all levels. Beyond that, we serve as a resource, on a day-to-day basis for people who have questions about how to comply with the employment plan, or when things go off track, how to get back on track. We observe and audit employment actions and assess compliance. From there, we develop strategies and procedures to achieve compliance. So if we, through our observations, we see that there are some opportunities that might involve creating job aids, offering, additional training opportunities, improving forms, or even recommending some, process changes. We do have an investigative process, as complaints, allegations of noncompliance with the employment plan are brought to us. We do investigate those. We do provide feedback, in the employment plan amendment process, and we also prepare semi-annual reports. Transparency, is important, and so, today I am presenting, an overview of the EPO 22nd semi-annual report, which was filed September 15th, and it covers the period of January 1st through June 30th. The full report, will be available, for review on our website and on our intranet. Next slide. Starting with what is new. So I did reference in the first slide, that there is an amendment process, for the employment plan. It is a living document, so as our operations, and needs change, the employment plan can be amended. That did happen, in the reporting period that I am covering here today. So, as you can see, we did, have an amendment for accelerated hiring. Though many of you are probably familiar with the concept of accelerated hiring because we did have a pilot, previously, we do now have a permanent accelerated hiring, process in place, as well as an emergency hiring amendment. So we have for some time had an emergency hiring process that was limited to temporary hiring. And so the amendment that was added, in the period that I'm covering today does, provide the opportunity for, permanent hiring in emergency circumstances, either through the, accelerated hiring process becoming the default, or by using, a hiring process that allows for very expedited, interviewing process, for positions that, meet the criteria to be actively recruited. So those are two new things, as well as transparency. Of course, I'm here today to present the EPO 22nd semi-annual report. That is a plan requirement, twice per year, so something to check out. Website transparency, again, very, very important. Over the years that as I come twice per year, I'm constantly continuously reporting on all things transparency related, opportunities, challenges, and progress. And in this past reporting period, there has been significant progress in terms of what is going on the website. HR has quarterly reports that they are required to put up, and there were some technical kind of challenges over time to get all of the types of data into the report that is required. One that was still lingering were settlements and awards that result in covered employment actions. And so, as you all know, there were settlement agreements that resulted in a lot of hires, conversions of agency to permanent employees recently. And so it was very important with that volume of that type of hiring to make sure that made it into our quarterly reports, and it did. So very pleased with that. New resources, of course, I'm sure you've probably heard this already, probably an HR report, but Karen Hughes started in the period that I'm covering as the Director of Talent Acquisition. As you know, the HR and the EPO are both very interested and responsible for oversight of plan compliance, and so having strong HR leaders can do nothing but help us from a compliance perspective. So very happy to have Karen. She has been coming with great enthusiasm, great ideas, and she's very compliance minded. So really looking forward to continuing to work with Karen. Next slide, please. Okay, so I'm going to go through everything on the slide in great detail. It's really just there to kind of to demonstrate. We're going to start with hiring. These are a lot of the hiring types that my office oversees and follows. And so just capturing here for you some of the notable observations that we've made relative to each of these types of employment actions. And then what was the resolution? How did we come in and try to, if there was an opportunity, how did we correct it? What are we doing to prevent that type of thing from happening again in the future. And so, again, all of this is fleshed out in the semi-annual report itself, but just really wanted to call out under the revised hiring process, the first section here, we noted a lot of really great catches by the recruitment team in this reporting period that were brought to our attention that would have otherwise resulted in non-compliance, may have resulted in having, lengthy delays or having to go backwards. And so we don't formally track, that's not a metric we formally track, but it was obvious enough as we were going through to prepare this report that we've been seeing a lot more of those than we ever have in the past. So I'm very happy to see that. Another thing, for example, with advanced clinical positions, there's a form that we noticed could use an update, brought that to HR's attention. So just kind of showing how the process works. Hiring fair process, as you all know, that's one of the temporary revised processes we've had. A lot of moving parts with revised hiring fair process. And in this past reporting period, CCH actually did participate in a fair that was run through offices of the president. So worked with HR to kind of adapt our process to be able to fit nicely in with that, both on the day of, and then to make some adjustments following the day of the fair, making sure that they still complied with the spirit of the employment plan. Next slide, please. And then just like hiring, we also monitor and follow several different types of non-hiring employment actions. And again, this is just up there to kind of show you the types of things that we observed, the issues that we identified in this particular reporting period, and then how we followed up to address those. Again, strategies to achieve compliance, support, oversight, all of those sorts of things. So, for example, with discipline, I've mentioned in the past, we, access the same repository of discipline that HR does when they get those, to screen those and to determine whether they are approved and ready to, for filing, or whether things need to be corrected because of a process or documentation violation. So, essentially we look at those and to the extent that we find something that we think is a significant concern, we refer those to the appropriate person within HR to take a look at those. But again, opportunities to reduce non-compliance, we continue to offer discipline refresher training that's optional for people who do implement training and who'd like a refresher. And there was recently the development of the discipline resources tool, which makes job aids and different source materials readily accessible to our leaders who are implementing. Next slide. Moving on, as I mentioned before, investigations are one of the functions in the office. Drawing your eye down to the little asterisk at the bottom of the slide, to those of you who were here back in March of 2023, we did report at that time, due to some chronic short staffing and then having to kind of pivot with the pandemic and the Great Resignation, our investigations backlog got significantly backlogged. So at that point, we had 130 investigations, and this board asked that we, really prioritize kind of reducing that backlog, and that we keep you apprised of where things are in terms of our investigations, the dates that they open, the dates that they close, et cetera. And we have continued to put a table in our report that you can look at that shows you exactly what that looks like through June of this year. But just a quick peek here, we did have a carryover of 16 from before predating 2025 when we entered the reporting period. At this point, we do have, we did close 8 of those. We had hoped to close all of those during that reporting period. We closed 8 of them. 8 still remain, and we definitely will continue to prioritize. And hopefully the next time I'm here, we will be able to report that there are no investigations that predate 2025. During the reporting period, we got 18 new ones, resolved 17 of them. Next slide. Okay, what's ahead, from a transparency perspective, again, transparency is super, important, obviously. One thing that I have stressed, is that we need to have a fully unified employment plan that is, available to the public and to ourselves. And so, as I mentioned, the employment plan, those two new processes were approved, during the reporting period. Those have not made it to the employment plan yet. That's, posted to the public, as well as those temporary revised processes, and one other process that were approved back in 2022. So again, it's just very, very important from, that the public can see what our processes are, and even inside of CCH, that we can see what our processes are. We need a single source of truth for our employees to look at for guidance, for HR to look at in guidance in what they do, and for us to look at as well. So I am happy to report that, there is active work on that, that started in July, and I'm very confident that by the next time I come back to talk to you, we will have a fully unified and, public employment plan. From a transparency perspective also, I spoke to you about those, big improvements on our website in terms of the quarterly report. There's just one little area left, to be fully compliant there, that HR is actively engaged in working on. Beyond that, we have recommended, some policy plan or process updates. As you'll see in the report, our interim assignment, interim pay policies, I recommend that those be updated, they're, to be in alignment, and, they're well overdue, for an update there. And then, training and overtime, we just need to make those more user-friendly, both for our leaders here, as well as for our office in how we oversee those things. Training is a huge, priority for this office during the next several months. We want to make sure that training for administrative support, gets rolled out. As you know, our administrative support personnel, play a role in, hiring. They really support the administration, preparing paperwork that goes to HR. And by getting them trained on how to catch errors before they make it to HR, I feel like that will, have a big impact in, improving compliance and reducing the time to fill. And then, we've got training that's due for HR personnel, and for our interviewers and supervisors, annual training. So, a big part of our focus will be getting that ready and getting that implemented. Next slide. And that's all I have for you today.
Thank you, Kim. Any questions? Thank you. Appreciate the,
Have a good one.
report. Given the time that we've, spent with other items, I'm going to ask that the Metrics Managed Care Committee report usually presented by Aaron Galiner, Chief Administrative Officer of Health Plan Services, and Metrics Human Resources Committee report, presented by Wynn Buren, our Chief Human Resources Officer, be, recorded and filed into the record. So we always enjoy listening and hearing from both presenters, but given time, we'll just file those and come back with any questions we might have. So the board will now go into a closed meeting. Action is not expected to be taken in open session after the discussion in closed session. So I'm asking for a motion to go into a closed meeting pursuant to the following exception to the Open Meetings Act 5 ILCS 1202C 1, 2, 11, 12, and 17. And we will need a roll call vote for that.
Second.
I heard a first and second. Any discussion, comments? Okay, I'll turn it over to the secretary to call the roll.
Roll call vote on the motion to go into closed session, aye or nay. Director Bott? Is absent. Director Green? Aye. Director Harrington?
Aye.
Director Kim? Aye. Vice Chair Lowry?
Aye.
Director Masuda Barnett?
Aye.
Director Ryder?
No, just kidding.
Director Robinson is absent. Director Sorrell? Aye. Director Staines? Is absent. Director Webster Cross?
Aye.
And Chair Garza?
Aye.
You have 9, yays and 3 ayes.
Okay. So
You guys didn't see this, but Maya was gonna back me up. She had the microphone ready.
So we'll just need a few minutes to clear the room, and then